Hi, this is a case study on Baker's cysts. So, a 42-year-old male with left knee pain that has been lasting around 9 months presented to an orthopedic clinic, and he had swelling behind his knee, and he stated that he had had increased pain with standing and limited knee flexion. He had been on some medication for the last 3 months due to his rheumatoid arthritis, and during the physical examination, a large mass was observed behind his left knee that expanded to the proximal calf. And the mass was immobile and soft when palpated, and his range of motion was not very good. And so a Baker's cyst was determined. So here we see his MRI on the left of the screen. Right here, you have the femur and the tibia, and this white part is the big cyst behind his knee that, as I said before, extends down to his proximal calf. And on the right, we have a normal looking sagittal MRI of a knee. So what is a Baker's cyst? A Baker's cyst is a fluid-filled sac behind the knee. It causes a bulge and a feeling of tightness and pain when the knee joint moves. It's the most common cystic lesion of the knee joint, and it is excess fluid from the gastrocnemius semimembranosus bursa sac. Here is another depiction of a Baker's cyst. On the right, we have the abnormal knee, and on the left is the normal knee, showing the knee joint and the normal-looking bursa sac and synovial fluid. And on the right is the Baker's cyst filled with excess synovial fluid that just kind of protrudes out the back of the joint. Here we see a longitudinal ultrasound of the Baker's cyst and the knee joint side by side with another drawing depiction of a Baker's cyst. And you can see the communication between the Baker's cyst and the knee joint cavity. It's just a slit-like pathway, and it is usually between the tendon of the semimembranosus and the medial head of the gastrocnemius muscle. Okay, here we see a ultrasound exam of a Baker's cyst, and we have figure B, which is the short axis view, and the Baker's cyst typically appears as a well-defined crescent-shaped anechoic cystic lesion, as you can see by the arrowheads. It's definitely cystic looking for sure. And the open arrowhead right here is really crucial for a Baker's cyst diagnosis because it is the fluid-filled neck, and that's the pathway into the cyst from the knee joint cavity. And so that is really important when diagnosing a Baker's cyst. And this figure D is the long axis view of the cyst, and the star, this is the medial head of the gastrocnemius, this is the body of the cyst, and the X is kind of the base of the cyst. So just another view of the long axis. So the most common cause of Baker's cyst is just non-infectious joint effusions, which is water around a joint. Too much water causes the Baker's cyst. And it is also common when there is meniscus, ACL tears. With those tears, the synovial fluid just seeps out of the joint capsule there. It's associated with osteoarthritis and rheumatoid arthritis. because these diseases are often associated with hypertrophy of the joint capsule and chronic inflammation of the bursa sac, which is an increase in size, and with that comes increase of synovial fluid, which causes the palpable mass in the back of the knee. And in our case, our patient has rheumatoid arthritis, and so that is definitely the most likely cause of his Baker's cyst due to the increase in synovial fluid that he has because of his disease. There are multiple treatment methods for a Baker's cyst. The most common is just aspiration of the cyst, which you extract the excess fluid from the joint, as you can see in the top pictures here. And that is done with the help of ultrasound. And there's also ultrasound-guided steroid injections. You can inject a steroid into the joint to relieve the swelling and the amount of fluid accumulation in the joint. If the cyst is bad enough, then you can remove the whole cyst, and you can also have an arthroscopy or arthroscopic debridement of the knee, which cleans up the knee of fluid and repairs the issues that cause the cyst, whether it be a meniscus or an ACL tear. It kind of goes in and finds those problems and issues and fixes them, as well as getting rid of the cyst. In our case, our patient did get an arthroscopy of his knee, which removed the cyst. So, as kind of a summary or discussion, is for our patient, in this case, his rheumatoid arthritis definitely caused an increase in fluid production that accumulated in the back of the knee, causing his Baker's cyst. But in other cases, joint effusion and tendon ligament tears can also cause this bursa sac to become distended and filled with fluid that is not normal. And there have been multiple treatments that have been found to be successful. Those 4 different treatments that I listed previously are all good at getting rid of Baker's cyst. It's just patient dependent on what they want. And in our case study, like I said before, he had an arthroscopy, and then later the cyst was surgically removed. And after that, he had full range of motion and no pain in all of his follow-up visits. There are some differential diagnoses that occur with Baker's cysts. If the patient has different symptoms, they need to be evaluated further to rule out deep vein thrombosis, popliteal artery aneurysm, ruptured cysts, and some malignant tumors can also have cystic characteristics like sarcomas, fibrosarcoma, and malignant fibrous histiocytoma. Just an example of a differential diagnosis: in the top figure, a middle-aged woman presented with a lump in the back of her knee, and that was a Baker's cyst. And another different patient, also a middle-aged woman, had the same palpable lump on the back of her knee, but hers was actually a popliteal aneurysm. Have the same symptoms, but definitely could be different diagnoses.